It is now my pleasure to have our last speaker, and this is back to Seema. Seema is a consultant who's really pioneered A&E in England as an actual ophthalmic specialty, and thus leads our Royal College of Ophthalmologists wing in A&E medicine. And I'm delighted that she can join me today to think about what she would get out of bed for in ophthalmic emergencies. Thank you, Seema.
Good morning, ladies and gentlemen. First and foremost, a very big thank you to SOE for their kind invitation to do this talk. Now, many things present to the eye casualty department, but we don't get out of bed for all of them. And so what we have to do is try and find a system by which we recognize what is important. So how urgent is urgent in ophthalmology? What are you going to get out of bed for? One of the ways to look at it would be to divide things into sight-threatening or life-threatening problems. And some of the things that cause unilateral sight-threatening problems are conditions like acute angle closure glaucoma or endophthalmitis. Bilateral sight-threatening problems could be things like uveitis or acute loss of vision from giant cell arteritis. And then we have things that are not only sight-threatening, but also they're life-threatening. So, for example, a third nerve palsy from a cerebral aneurysm, or an endogenous endophthalmitis in a patient that's a drug abuser. Now, if we look at what the reality is in terms of what comes in to the hospital, we did an audit at St. Thomas's Hospital looking at the top 10 sight-threatening conditions. And you can see that our top 10 is not that different from the published top 10 by the Mayo Clinic. And I'm sure that it's not that different from what you see in your units. So amongst them, acute angle closure glaucoma, endophthalmitis, orbital cellulitis, retinal detachment, retinal artery occlusion, giant cell arteritis, chemical injury make up the bulk of the presentations. So I think the way to decide whether you're going to get out of bed or not is around looking at pattern recognition. Okay, the eye can only tell you in certain ways that it's not well. It can become red, it becomes painful, the vision decreases, or it develops double vision, or there may be a combination of these things. But it's the history. It's the history that will tell you whether something is important or something is not important for you to get out of bed in the middle of the night. So the history, the examination, and then you've got to have a differential diagnosis. So pattern recognition. Let's look at pattern recognition. Eyes can present with either sudden loss of vision or gradual loss of vision. And these things can be painful or painless. And that's one way that you can look at the whole system. And here on this slide, I've put down some of the things that cause painless loss of vision and some things that cause painful loss of vision. And then you've got anterior ischemic optic neuropathy that can do both. And it's the history that will tell you whether it's non-arteritic or it's arteritic. So let's start with ocular trauma. Now, you'll see a lot of this for which you may need to get out of bed for, and they can be divided into high impact or low impact injuries. And they can cause hemorrhage, orbital wall fractures, globe ruptures, lacerations, and of course, they can present as chemical injuries. Now, in this 10-minute talk, I can't go through all the things, but I thought I would talk about retrobulbar hemorrhage. This is an emergency. There's no time to investigate in terms of, shall we do a CT scan? Because the problem is the optic nerve is at risk and you are at losing that patient's vision. And so it's the history of trauma, and then the signs, the clinical signs, a poor vision, an eye that is proptosed, a tense orbit, and of course, the presence of an RAPD. If you have this, I think you need to perform a lateral canthotomy well before you start to do any kind of investigation. The other emergency, which is not only an eye emergency, but also a medical emergency, is central retinal artery occlusion. Now, central retinal artery occlusion will present with profound, sudden, painless loss of vision. And again, when you examine this patient, you may find that they're diabetic or they suffer with high blood pressure, and that they have an RAPD and very poor vision. When you look into the eye, you may find a cherry red spot, a retina that looks very pale, and you may even see the presence of emboli. And the treatment involves reducing the ocular pressure. And the other important thing is that these patients need to be referred to the stroke unit, as this could be a presenting sign of a stroke. Now, one of the presenting features of giant cell arteritis can be a central retinal artery occlusion. So giant cell arteritis usually affects people who are older than 50 years of age. And most of these patients will present with a history of a headache, they've not been well, maybe there's been weight loss, there's scalp tenderness, so when they brush their hair, their head feels sore, there may be jaw claudication, they may have proximal weakness relating to polymyalgia rheumatica, or they may present with profound loss of vision. And again, there may be reduced color vision, there may be an afferent, you may see a central retinal artery occlusion, they may even present with a cranial nerve palsy and present with diplopia. And the investigation is urgent ESR, and the treatment is high dose steroid. And this can be oral, it doesn't have to be IV, but it needs to be given promptly, because if you don't, these patients are at risk of losing not only the vision in the affected eye, but soon the vision in the unaffected eye. Once that has been given, then you can think about temporal artery biopsy, and if you have access later on to an ultrasound, you can ultrasound the artery. The most devastating for all of us is postoperative endophthalmitis. And so these are patients that develop infection post-intraocular surgery. And they present themselves with sudden onset of rapid and progressive loss of vision, pain, and redness of the eye. And again, the examination can vary from slightly reduced vision to profound loss of vision associated with lid edema, conjunctival chemosis, a purulent discharge, a poor red reflex, and as you can see in this picture, a hazy cornea and a hypopion. The treatment, of course, for these patients is aqueous and vitreous sampling pretty quickly, and followed promptly by intravitreal antibiotics. Now, all your units will have their own protocols, which you need to get yourself familiar with, but prompt treatment is what needs to be done. You cannot delay this, because the more you delay, the worse the prognosis for these patients. The other emergency for eyes is acute angle closure glaucoma. So here, patients will present with sudden, painful loss of vision, and most of these patients will be in a lot of pain. Some will be vomiting as a result of the raised intraocular pressure. And people that we see this condition in are people who are hypermetropes. And the cornea will be hazy, the pupil would be mid-dilated, the eye will be very red. And the treatment is to reduce the pressure, to get that intraocular pressure down with intravenous Diamox and topical antihypertensive treatment. And before the patient leaves your unit, a peripheral iridotomy, not only to the affected eye, but also to the unaffected eye, as that eye also is at risk of developing acute angle closure glaucoma in the future. Finally, orbital cellulitis. Again, this is an emergency, because if it's not treated, the vision goes because of the damage to the optic nerve. So how do these patients present? Sometimes they will present with a preseptal cellulitis, which can then become orbital cellulitis. So they will present either with a history of a cold or a cough, or they will present with pain, lid swelling. And although the lid is swollen, it is our job to open that eye and look at the eye. Is the eye red? What's the motility of the eye like? What is the vision? Is there a presence of reduced color vision? Is there a presence of an RAPD? All of which is telling you that the optic nerve is vulnerable. These patients require prompt IV antibiotics. And again, your units will have the protocols that you will follow. These patients require CT scans of their sinuses. And you need to involve the multidisciplinary teams, such as the ENT team, and if it's a child, then the pediatric team, because this requires a multidisciplinary approach to treat the patient. So that was a whistle-stop tour of why I would get out of bed and why you should get out of bed for ocular emergencies. And again, I'd like to thank SOE for their kind invitation, and I hope you enjoy the rest of the session. Many thanks.
Thank you very much, Seema, for that very enlivening talk. Luckily, as an orthoptist, I don't usually have to get out of bed for very much, but my heart goes out to the ophthalmologists that do.